Bismillahirrahmanirrahim. Good morning, everyone. Today we are going to discuss about ultrasound for common uterine pathologies, and I am Professor Dr. Sayyid Amir Gilani. When we talk about endometrium, it depends either the endometrium is to be assessed in a normal cycle, a menstrual cycle, or it is postmenopausal. When it is in the menstrual cycle, it again depends either it is in the proliferative phase, in early proliferative phase, or late proliferative phase, or secretory phase. In postmenopausal women, we know that there will be a thin echogenic line due to atrophy. The thickness of the endometrium decreases, so there will be atrophy of the endometrium. Therefore, myometrium may be seen as a subendometrial hypoechoic hollow, and the endometrial thickness is very important. Another important thing when we talk about the endometrial diseases is endometrial hyperplasia. Non-specific thickening of the endometrial lining can be caused by estrogen overstimulation, common cause of uterine bleeding. So when we get especially a woman with uterine bleeding, we have to keep in mind that the patient may have overstimulation by the estrogen, or the patient can have postmenopausal bleeding due to tamoxifen therapy or due to estrogen overstimulations due to some medication. In tamoxifen therapy, we can have irregular thickening of endometrium with cystic changes. It appears like this. We will have endometrium. This is whole of the endometrium. Endometrium is having hyperplasia with cystic areas in it. So this was a patient with tamoxifen therapy. When we use transvaginal ultrasound with color Doppler, we can assess the endometrium and its vessels. Here you can see the color signals at the periphery of the endometrium. The resistive index is around 0.48. We usually take normal when it is above 0.50. So in this case, it was relatively lower. Another important disease of the endometrium is endometrial polyps. Hyperplastic or adenomatous endometrial tissues. On ultrasound, we get discrete mass within endometrial cavity. Some endometrial cancers and polypoids and some mucosal are pedunculated. Here we can see the endometrial cavity with some fluid inside, and this is one polyp lying here near to the fundus. So when we get the endometrial polyp, we can use color Doppler. This is a spectral Doppler along with the polyp. The moderate vascular resistance is about 0.48 plus minus 0.06, but we can have infection or necrosis which would influence the blood flow, and here is 0.56, which is a bit higher resistive index in this case because of the polyp. This is another case of the endometrial polyp. Within the endometrium there is a polyp, and when we put on colors, we will get a feeding vessel, usually a single feeding vessel which is supplying the polyp, and then we assess the resistive index of that polyp to assess either it is changing into a malignant polypoid mass or it is just a benign polyp. A few more cases of the polyps here. You can see this is the endometrium, and here we have a polyp, and this is another polyp in the endometrium having some small cystic changes, and this is again a polyp. We can use 3D to assess these pathologies. Here is a polyp inside on 3D, and here is again a 3D for the endometrial polyp, a rounded structure, a single polyp there. Another endometrial disease is the endometrial carcinoma. usually found in postmenopausal women which are above 50 years of age. Increased risk associated with an unopposed estrogen stimulation, and it is linked with obesity, diabetes mellitus, hypertension, nulliparity, late menopause, polycystic ovaries, or we can have it due to deficiency of the or disturbed hormones. The endometrial carcinoma, it will be a hyperechoic structure or inhomogeneous endometrium is seen. It can be irregular. The outline is disturbed because of the invasion of the carcinoma into the walls. There will be disruption in the endometrial, subendometrial layers. Here is endometrial carcinoma, a malignant mass, multiple feeding vessels that are low resistant, and usually they range about 0.4, about 0.45, usually less than 0.5. This is a case of endometrial carcinoma, excessive feeding vessels, and you can see the resistive index is very low, 0.37. So anything which appears irregular in the endometrium on color Doppler giving multiple vessels, engorged vessels, on spectral Doppler the resistive index is less than 0.5 is indicative of a carcinoma, a malignancy originating from the endometrium. Here is the intratumoral blood flow. In the endometrium, we can see this is a mass having cystic areas inside. There is a feeding vessel, and resistive index is 0.300, which is indicative of a malignant mass. Another case of the endometrial carcinoma on grayscale, and then we have the power Doppler. Then comes the endometrial disease, which is called Asherman's syndrome. Normal endometrial linings replaced by fibrous adhesions, usually secondary to previous DNC or multiple abortions or infections. Sonographically, varying appearance, we can have normal endometrium, thin endometrium, or thick endometrium, so it varies. How we diagnose the Asherman's syndrome is important. There will be hyperechoic band-like structures, the fibrous structures inside. Here it is with 3D. You can see the hyperechoic intrauterine fibrous structures, which are the adhesions. So common ultrasound findings and differential diagnosis of the thickened endometrium includes endometrial hyperplasia, endometrial polyps, carcinoma, Asherman syndrome, and retained products, which are the retained pieces of conception, which are also abbreviated as RPOCs. In thick endometrium, it can be due to hormonal imbalances like pituitary or ovarian abnormalities. It can be due to postmenopausal endometrium and Asherman syndrome. So these are three main differential diagnoses for thin endometrium. For intrauterine fluid collections, the causes are congenital obstruction like imperforate hymen, vaginal septum, or atresia. Acquired obstruction like uterine malignancy, radiotherapy, scarring, or foreign bodies. Postmenopausal patient, if it is a benign process, we can find cervical stenosis, and if it is malignant, we can find endometrial or cervical malignancies. This is a case of intracavitary fluid collection, endometrial carcinoma. You can see the outline of the endometrium. There is a mass inside intracavitary or endometrial carcinoma. These are few nodules of that carcinoma, and we have got some fluid inside along with that lobes of mass. Another important thing is the vascularized septum in the uterus, which is going up to the endometrium, and if there is vascularity, we can assess the vascularity. In this case, it will always be above 0.5. As it is septa, it is a benign structure, so the resistive index will be above 0.5. This is another case in which the color and pulse wave Doppler studies were done for the septum. In the endometrium, the vascularization of the septum indicated that resistive index of 0.68, the normal range for vascularization of septum, if we consider the resistive index, the normal range is 0.68 to 1. And the vascularity of the septum is seen in 71.22%. This is the 3D of the septate uterus. Here you can see the septa inside, so the vascularity will be here. This is the complete septa showing two endometriums, a unicornuate uterus in which we can see the endometrium here. This is the uterus having single cornate, single endometrium. Then we come to the leiomyomas, the most common benign gynecological tumors with increased incidence in women who are around or above 35 years. It is a circumscribed spherical mass arising from the smooth muscles of the myometrium. They are not capsulated but develops a false capsule or compressed myometrial tissues. The leiomyomas, which are commonly called fibroids, atrophy and vascular changes cause the fibroid to undergo degeneration, which can cause fibrotic changes, hemorrhage, necrosis, and calcification. Respond to estrogen, may enlarge rapidly in pregnancy, and may shrink during menopause. The leiomyomas can be seen at different locations. We can find them at broad ligament. They stimulate adnexal mass. We can have cervical myomas. We can have intramural, which are most common. And we can have submucosal, cause the most symptoms, pedunculated and extend out of the cervix. And the last type is subserosal fibroids. On ultrasound, we will have large range of appearance. The classic appearance is a fibroid or leiomyoma on ultrasound will be homogeneous, hypoechoic, discrete mass with poor sound through transmission and dropout. Multiple fibroids can appear with a large inhomogeneous nodulated uterus with lobulated contours. Upon degeneration, they can calcify, become more cystic, or undergo fatty degeneration. This is a fibroid, which is submucosal fibroid, is the endometrial cavity. Outside of the endometrial cavity, this side of the endometrial line is distorted, and we have a large submucosal fibroid. A fibroid with cystic degenerative changes here and calcifications in a submucosal leiomyoma, a fibroid having calcifications. This is the endometrium, and we have got a myoma, a fibroid here with the spiral vessels. So regularly separated peripheral vessels are there, which can demarcate the outline of the myoma. In this case, you can see the range is 0.54 plus minus 0.08, and in this case we had resistive index of 0.538. On B mode, a case of submucosal myoma, a fibroid which is submucosal in appearance, then putting some colors and getting the spectrum. This is another case on grayscale, and the appearance on color Doppler shows that it is sarcoma, a malignancy, a fibroid which changed into a leiomyosarcoma. Uncommon, rapidly growing, aggressive malignancy arising from pre-existing leiomyomas. Then is a condition which is called adenomyosis, ingrowing of the endometrium into the myometrium. So the endometrial tissues, they grow into the myometrium. It affects about 20% of women, mainly multiparous women. The symptoms are bleeding, pain, and infertility. Especially the lady will have increased pain during menstruation, as the endometrial tissues which are implanted in the myometrium, in the muscles of the uterus, will also bleed. So they will appear cystic like this. If we scan after the menstrual days, we will not find these cystic areas in most of the cases. So findings will be enlarged uterus without fibroids, and during the menstrual cycle, if it is scanned, then there will be cystic areas, means bleeding from the endometrial tissues which are implanted in the myometrium. So there will be disturbed echogenicity of the middle myometrial layer, hypoechoic myometrium, and multiple small cysts in the myometrium due to bleeding or coagulation. On color Doppler, there will be increased vascularity characterized with moderate vascular resistance within myometrium. The resistive index ranges from 0.56 plus minus 0.12. Here are the adenomyosis on grayscale cystic areas and color flow. Then comes the molar pregnancy. In molar pregnancy, there will be snowstorm appearance on grayscale. This is with the color Doppler. Appearance, the mole is compressing the vessels, so increasing their velocity and resistive index. Here you can see the resistive index is 0.400. This is another case of the snowstorm appearance, which is the molar pregnancy. Then comes the pelvic inflammatory diseases, which is also called PID. Acute PID may occur following surgery, but usually is a result of ascending infection and associated with intrauterine contraceptive devices. The chronic PID can involve adhesions, edema, hydrosalpinx, pyosalpinx, and ovarian pathologies. This is a case of hydrosalpinx within the tube. There is fluid inside. Acute PID. This is in the tube. Here is more fluid inside, and we can see the resistive index unmeasured at the endometrium is 0.34. This is a case of chronic PID. Excessive fluid seen in the pouch of Douglas. These were the most important pathologies of the endometrium, which are seen along with the myometrial pathologies and pelvic inflammatory diseases. Thank you for listening. Thank you very much.